You know, usually when we talk about a medical diagnosis, there's this underlying expectation of precision.
Right, like it's totally black and white.
Exactly. I mean, you break your arm, the x-ray shows a jagged white line, and the doctor just points to the screen.
Yeah,
It's broken or not broken. It feels clean, it feels binary.
completely.
But when you step into the world of pediatric safeguarding, suddenly that x-ray machine is just broken.
It really is.
We're looking at this huge stack of sources today for you.
Yeah.
Clinical protocols from the Royal College of Pediatrics and Child Health, guidelines from the UK's National Institute for Health and Care Excellence, which is also known as NICE, and Standard Dermatological Manual.
Right, a lot of heavy material.
Yeah, and reading through it, you realize the diagnostic landscape is terrifyingly murky.
Oh, absolutely.
Okay, let's unpack this. The mission for this deep dive is to really understand a specific, highly consequential intersection in pediatric medicine.
Which is so crucial to get right.
Right. We are navigating the absolute minefield between identifying signs of child sexual abuse and diagnosing a rare mimicking autoimmune condition called pediatric lichen sclerosus.
And, the clinical data really backs up just how consequential this is.
Yeah.
Yeah, I mean, to understand why a mimicking skin condition is so dangerous in this context, we first have to look at the baseline of what pediatricians are constantly on alert for.
Which is a lot.
It is. The sources highlight this really sobering statistic: contact abuse affects at least 1 in 20 children.
Wow. 1 in 20.
Yeah. And because of that staggering prevalence, frontline healthcare workers have to operate with an incredibly low threshold of suspicion.
Right. They can't take any chances.
Exactly. When they observe certain physical red flags in the anogenital region, like unexplained bleeding, lacerations, severe bruising, they don't wait around.
They just act.
Right. When a child presents with these, clinicians are trained to initiate immediate safeguarding protocols.
Which, I mean, that makes total sense. You're basically asking a pediatrician to act as a forensic investigator at a highly ambiguous crime scene.
That's a really good way to put it.
Except in this scenario, the witness, the child, might be completely pre-verbal.
Right.
They might be an infant, or if they're older, they might be too terrified or traumatized or groomed to even disclose what actually happened.
Exactly. So the doctor has to rely entirely on the physical clues left behind.
Yeah, the physical footprint.
And the challenge deepens when you consider that, behavioral clues can be equally ambiguous.
Oh, for sure.
A child experiencing trauma might become selectively mute, or they might exhibit sudden severe distress, or even begin self-harming.
Which are huge red flags.
They are critical distress signals, yes,
Yeah.
but they don't reveal the actual mechanism of the injury.
Right, they don't tell you how it happened.
No, they don't. That pushes the diagnostic burden heavily onto the physical examination. Clinicians are taught to aggressively scrutinize injuries that simply do not align with the developmental stage of the child.
Like the sentinel lesions mentioned in the guidelines.
Exactly. The pediatric guidelines refer to sentinel lesions. These are seemingly minor injuries, perhaps a scratch or a small bruise found on a non-mobile infant under 6 months old.
Right, because a baby who lacks the motor skills to crawl or roll over just shouldn't be accumulating bruises.
Precisely. Because they aren't out there bumping into coffee tables or tumbling off playground equipment.
Their environment is entirely controlled by their caregivers.
Exactly.
And even when they do get mobile, I was looking at that screening tool mentioned in the NICE guidelines, the 10-4 faces rule.
Oh, that's a brilliant tool.
It's fascinating, right? Because it focuses entirely on the biomechanics of how toddlers actually get hurt.
Right, the physics of a fall.
Yeah, like when a 2-year-old takes a spill, they predictably hit the bony prominences of their body.
Yeah.
The forehead, the knees, the bridge of the nose.
The standard toddler bumps.
Exactly. But this rule flags bruises on the torso, ears, and neck. That's the 10 part. And it flags bruises on the soft, fleshy parts of the cheeks or the angle of the jaw.
Which is the faciest parts.
Right. You don't bruise those soft tissues by tripping on a rug.
No, you really don't.
You bruise them when you are grabbed or struck.
And that biomechanical logic is really the foundation of pediatric safeguarding. If the physical evidence defies the mechanics of a normal childhood accident, well, the clinician must assume inflicted trauma until proven otherwise.
They have to.
This raises an important question. How does a doctor interpret physical evidence when the behavioral context is murky and the physical evidence itself is essentially producing a counterfeit crime scene?
And that brings us to the core mystery of our deep dive. Enter lichen sclerosus, which the dermatological standards paint as the absolute master mimic.
It really is the master mimic.
We've established that the physical footprint of abuse involves bruising, tearing, and bleeding in the genital and anal regions.
Right.
Now we are pivoting to a naturally occurring medical phenomenon that produces an almost indistinguishable physical presentation.
So, leak sclerosis, often abbreviated as LS, is an uncommon inflammatory skin condition.
Okay.
The critical starting point here is understanding that it is an autoimmune disorder.
So definitely not an infection.
Exactly. It is not an infection, and it is entirely non-contagious.
Got her.
The child's own immune system is basically misfiring. It mistakenly identifies the healthy skin of the anogenital region as a threat, and it launches a localized attack against it.
The bimodal onset pattern mentioned in the sources is a massive clue to how this disease operates, I think.
It's a huge clue, yeah.
Bimodal meaning, the diagnosis rates spike into very specific, hormonally distinct demographic windows.
Right.
It primarily strikes postmenopausal women, but that first spike happens in prepubertal girls, typically between the ages of 5 and 7.
And the visual hallmark of this immune attack is just striking.
What does it actually look like?
Well, the affected skin develops patches that are porcelain white and dramatically thinned out.
Oh.
Yeah, and it frequently forms a very distinct figure-of-8 or keyhole pattern that rings around the vulva and extends down around the anus.
A figure of 8.
Yes. And the tissue loses all of its natural elasticity. It becomes fragile to the point of behaving like wet tissue paper.
And here's where the mimicry starts to make terrifying sense.
It really does.
If the immune system is actively degrading the structural integrity of the skin, the capillaries situated just beneath the surface lose their protective padding.
Right, they have no cushion.
They become insanely vulnerable. I mean, I'm looking at the medical texts emphasizing that LS presents with profound subcutaneous pooling of blood and painful fissures, which are basically just tears in the tissue.
Exactly, microscopic tearing.
You don't even need blunt force trauma to cause a horrific-looking injury.
No, you don't. The catalyst for that injury is actually the secondary symptom of the disease, which is this maddening, relentless itching.
Which the sources say typically peaks at night, right?
Yes, mostly at night. The child is asleep, experiencing severe pruritus, which is the medical term for that itch, and their natural reflex is just to scratch.
Even while asleep.
Even while asleep, they are fiercely scratching tissue that has the structural stability of wet tissue paper.
That's horrifying.
The sheer friction of fingernails in their sleep, or even something as mundane as wiping with toilet paper or the chafing of a bicycle seat, is enough to rupture those unprotected capillaries.
So the blood pools beneath the skin, creating massive dark bruising, and the tissue simply splits open under the friction.
Yes.
To a clinician rushing through a busy emergency room shift, or someone whose primary lens is child protection, that doesn't look like an autoimmune flare-up.
Not at all.
It looks exactly like the lacerations and impact injuries associated with a violent sexual assault.
And, the overlap doesn't stop at the visual evidence.
Yeah.
The clinical guidelines highlight a devastating behavioral overlap as well.
Really? How so?
Because the disease process frequently extends to the perianal area, it creates those painful fissures around the anus.
Okay, the tears.
Right. So a 5-year-old child quickly learns that having a bowel movement is going to cause them excruciating pain.
Oh. So they do what any of us would do if something hurt.
They avoid it.
They withhold their stool, which leads to severe chronic constipation.
Exactly.
But if we flip back over to the nice safeguarding guidelines, sudden, severe, unexplained constipation or soiling is explicitly listed as a potential behavioral indicator of abuse.
It is.
The diagnostic waters are just completely muddy.
Muddy is an understatement.
The doctor observes genital bruising, anal tearing, and severe constipation. Every single alarm bell for abuse is ringing at maximum volume, yet the culprit is an internal immune system misfire.
You can see the gravity of the situation. A well-meaning clinician, highly trained to advocate for the safety of the child, could very easily trigger a traumatic, multi-agency child protection investigation based entirely on the natural physical manifestations of lichen sclerosus.
Here's where it gets really interesting, because if you are listening to this and thinking, okay, the challenge is simply for the doctor to be meticulous enough to choose between diagnosis A, which is abuse, and diagnosis B, which is lichen sclerosus.
It's not that simple.
The medical reality throws a massive curveball into the mix.
It really does.
The sources reveal that a diagnosis of LS does not medically or legally rule out sexual abuse.
No, it doesn't.
In fact, they can exist simultaneously.
The mechanism behind this simultaneous presentation is something known as the Koebner phenomenon.
Koebner phenomenon.
Right. It is a recognized medical quirk observed in several dermatological conditions, including psoriasis, vitiligo, and lichen sclerosus.
I've actually heard of the Koebner phenomenon in relation to psoriasis.
Oh, you have?
Yeah, like if someone has psoriasis and they get a deep scratch on their arm from a rogue tree branch, as that scratch heals, the immune system overreacts.
Exactly.
And it forms a thick psoriasis plaque directly over the site of the physical trauma. The injury acts as a magnet for the autoimmune response.
That exact cellular mechanism applies to lichen sclerosus.
Wow.
Imagine a child who carries a latent genetic predisposition for LS, or perhaps has a very mild asymptomatic case that hasn't bothered them at all.
Okay.
If that child is subjected to the horrific physical trauma of sexual abuse, the sheer damage to the anogenital tissue can Koebnerize the area.
It triggers it.
Yes, the inflicted physical trauma actively triggers the underlying immune disease to erupt at the precise site of the assault.
That is staggering. The abuse literally acts as the spark that ignites the autoimmune disease.
Precisely.
So a clinician can't just spot the porcelain white figure of 8 pattern, correctly identify LS, and send the family home believing they've definitively ruled out trauma.
Absolutely not.
The presence of the disease might actually be the footprint of the trauma.
And the clinical guidelines are incredibly rigid regarding this overlap. Identifying lichen sclerosus provides a verified medical explanation for the fragility of the skin, but it absolutely does not close the door on a safeguarding investigation if there are other contextual red flags.
So how do they separate the two? I mean, if the presentation is identical, how does a doctor know if they are looking at naturally occurring LS or LS that was violently triggered by an assault?
Well, the British Association of Dermatologists guidelines provide a specific framework of clues to help clinicians untangle this.
Okay, but what are the clues?
The first major indicator is the age of onset. We establish the standard bimodal window. The disease typically surfaces in girls between 5 and 7.
Right.
If the symptoms suddenly explode in an older prepubertal girl, perhaps a 10 or 11-year-old, that falls outside the expected hormonal and developmental window.
So that's suspicious.
Yes, that irregularity is considered highly suspicious and demands deeper investigation.
Another obvious red flag in the sources is the co-occurrence of a sexually transmitted infection.
Yes, that's a major one.
Because if a child tests positive for an STI, the presence of lichen sclerosus obviously does not offer any medical explanation for how that infection was contracted. The two diagnoses run parallel.
Exactly. And the final major warning sign is a complete failure to respond to standard medical treatments.
Okay.
If the patient is prescribed the correct high-strength interventions and the tissue is still failing to heal, clinicians are forced to ask a difficult question.
Which is?
Is this an unusually stubborn case of LS, or is the healing process being actively derailed because the tissue is being subjected to ongoing, repeated physical trauma?
Man, this sounds like an impossible tightrope for a pediatrician.
It's incredibly difficult.
You are trying to manage a painful, highly distressing skin condition for a child while simultaneously holding the legal, emotional, and social fate of an entire family in your hands based on how you interpret a bruise.
It's a huge burden.
How do they navigate that objectively?
They remove the subjectivity from the initial examination by relying on highly standardized forensic protocols. One of the central tools highlighted in the forensic guidelines is the Adams classification.
Based on the sources, it seems like the Adams classification is basically designed to stop a doctor's brain from jumping to conclusions.
That's a great summary.
It forces them to categorize genital findings into very specific, objective buckets before they try to assign a cause.
It acts as an analytical brake pedal.
I like that. A brake pedal.
The classification requires the examining doctor to document the exact morphology of what they are seeing. They cannot simply write suspected abuse in a medical chart.
Right, because that's a subjective interpretation that could instantly derail a family's life.
Exactly. Instead, they must objectively state something like, I observe a 2-millimeter fissure at the 6 o'clock position, or I observe porcelain white thinning of the labia.
Just the facts.
Just the physical facts. They then cross-reference those objective findings against known categories. These range from normal anatomical variants, because human biology has a vast amount of natural variation that might look alarming to an inexperienced eye, to medical conditions like LS or severe strep infections, all the way to findings that are exclusively associated with penetrating trauma.
It brings cold, objective science into a space that is inherently charged with intense emotion and panic.
It really is necessary.
Now, we've focused heavily on the presentation in young girls, but diagnostic bias is a real danger here, too.
Oh, absolutely.
If doctors expect this to be a girl's disease because of that bimodal demographic spike, they might completely miss the diagnosis when it presents in boys.
And the surgical journals in our source stack make it clear that while it is less common, prepubertal boys absolutely develop lichen sclerosus.
They do.
However, the physical presentation is entirely different, which really contributes to that diagnostic blind spot.
How is it different?
In boys, the autoimmune attack almost exclusively targets the prepuce, which is the foreskin.
And the mechanics of the scarring process create a mechanical barrier.
Right.
As the immune system attacks the foreskin, the tissue loses its elasticity and becomes heavily scarred and inflexible, resulting in a condition called phimosis.
Yes, phimosis.
The foreskin becomes so tight it literally cannot be retracted, causing significant pain and recurrent urinary issues.
And the scarring can progress to the point where it constricts the actual opening of the urethra, creating meatal stenosis.
Which sounds awful.
It's a dangerous narrowing of the urinary pathway. When the disease reaches that level of structural restriction in boys, the first line of defense remains topical treatments, but frequently, the recommended curative approach is circumcision.
Okay, surgery.
Yes. The surgical removal of the constricted tissue resolves the immediate mechanical issue, though standard medical protocol dictates that the excised tissue must always be sent for a biopsy.
To definitively confirm the presence of lichen sclerosus.
Exactly.
Which transitions perfectly into how we actually treat this condition and shift the focus from investigating trauma to initiating healing.
Yes. The good news.
The good news across all these protocols is that lichen sclerosus, when properly identified, is highly treatable.
It is. The gold standard treatment, universally recommended across both the dermatological and pediatric guidelines, is the application of ultrapotent topical corticosteroid ointments.
Ultrapotent steroids.
Yes, because LS is fundamentally an overactive immune response. Applying these strong steroids directly to the lesions suppresses that localized immune attack.
It just shuts it down.
Exactly. It halts the inflammation, stops the maddening itch, and gives the thinned-out tissue a chance to actually rebuild its structural integrity.
The sources also put a massive emphasis on environmental modifications.
Huge emphasis.
It sounds basic, but apparently it is critical for managing the fragility of the skin.
It really is.
The guidelines advise a total overhaul of daily hygiene practices. Families are told to eliminate bubble bath entirely, stop using perfumed soaps or wipes, avoid tight clothing or synthetic materials like nylon tights.
Basically anything irritating.
Yeah. And even have the child sleep without underwear to minimize moisture and friction. The goal is to aggressively remove any external irritants that could provoke that hyposensitive tissue.
And if they do all that, the long-term prognosis for pediatric cases is largely optimistic.
That's a relief.
The data indicates that for the majority of children, the condition either fully resolves or vastly improves as they enter puberty, and their internal hormonal landscape undergoes a massive shift.
Oh, that's interesting.
However, resolution is not guaranteed for everyone, and some individuals will continue to battle flare-ups into adulthood.
And there is a significant caveat regarding that long-term monitoring, though.
A vital one. While pediatric lichen sclerosus is not cancer and does not directly cause cancer, individuals who endure chronic inflammation and scarring from LS have a small, yet statistically significant, increased risk of developing squamous cell carcinoma.
A specific type of skin cancer.
Right. A specific type of skin cancer later in life. Because of that elevated risk profile, patients require periodic monitoring by a dermatologist or gynecologist for the duration of their lives.
If we pull back and look at the sheer complexity of everything we've discussed, the visual mimicry, the Koebner phenomenon triggering disease from trauma, the subjective biases, it becomes incredibly obvious why navigating this cannot be a solo endeavor for any single pediatrician.
If we connect this to the bigger picture, the Royal College of Pediatrics and Child Health Guidelines are emphatic about this. Safeguarding requires a multi-agency infrastructure. General pediatricians are highly trained to recognize when a presentation deviates from the norm, but they are not expected to be the final arbiters of complex dermatological diagnoses or forensic investigations.
No one person could be.
Exactly. If a frontline doctor observes bleeding, tearing, or scarring in the anogenital region that they cannot definitively trace back to a clear medical cause or a verified witnessed accident, protocols dictate they must immediately escalate the case to specialists.
This usually involves convening a strategy discussion with social care professionals, law enforcement, and specialized forensic pediatric physicians at a sexual abuse referral center, commonly known as a SARC.
The SARC is vital.
It's a system explicitly designed to cast a safety net that is robust enough to catch genuine victims of abuse, while simultaneously employing a fine enough filter to catch medical mimics like lichen sclerosus before a family is subjected to a devastating, unwarranted accusation.
It's delicate balance.
So what does this all mean for you
Yeah.
listening? This deep dive highlights the immense, almost incomprehensible responsibility placed on the shoulders of the clinicians who first examine these children.
It really does.
They are staring at a presentation that could be the aftermath of a violent crime, the natural progression of an autoimmune disease, or through the cruel biological twist of the Koebner phenomenon, both at the exact same time.
Which is terrifying.
Understanding these nuanced mechanics, knowing why a porcelain white patch forms, understanding how extreme itching leads to subcutaneous bleeding, it gives you a shortcut to being truly well-informed about how complex medical truth actually is. The X-ray machine of easy answers is broken.
The reality requires incredible nuance. And if there is one final profound takeaway hidden within these sources, it is found in a specific note within the RCPCH protocols regarding those specialist forensic examinations at the SARC.
Oh yeah, this part is amazing.
We culturally tend to view forensic exams through a cold clinical lens. We assume they exist purely to gather trace DNA, document injuries for the legal system, and build a case for court.
Right, just a sterile evidence-gathering procedure.
But the clinical sources explicitly state that these specialized examinations serve another, equally vital purpose, providing crucial reassurance to the child.
That is so powerful.
Consider the internal psychological landscape of a child who has either endured the trauma of assault or who has been suffering from the excruciating pain, bleeding, and physical degradation of severe lichen sclerosus.
Yeah.
Children often internalize this physical reality. They develop a deep-seated belief that they are fundamentally broken, permanently damaged, or ruined in a way that can never be undone.
They just carry that myth of being physically destroyed inside them.
They do. Now, imagine the profound therapeutic power of a skilled forensic pediatrician in that moment. Using a specialized magnifying tool like a colposcope, they can conduct a gentle, objective examination.
Right.
For an older child, they might even show them the screen. They use their medical authority not just to gather evidence, but to definitively dismantle that myth of brokenness. They can look a traumatized child in the eye and explain the mechanics of their own body. They can say, "You are healing, your body is strong, you have a medical condition or you have an injury, but you are not permanently damaged."
That is a staggering paradigm shift.
It really is.
The exact same clinical tool used to secure a criminal conviction is being utilized as a direct psychological intervention.
Yes.
It sets the child free from the belief that their body is a permanently ruined crime scene. It completely alters how you view the murky diagnostic landscape we started with.
It adds so much humanity to it.
It does. The waters are undoubtedly muddy and the mimicking conditions are masterful, but with rigorous protocols, objective science, and an understanding of how the body responds to trauma, clinicians can do more than just find the truth. They can actually initiate the healing.
Absolutely.
Thank you for diving into the deep end with us today. Keep questioning the mechanics of how things work, keep exploring the nuances, and we'll catch you on the next one.